So now we'll move on to the next session, and I'm happy Dr. Angira Das Gupta has joined with us. Actually, Madam needs no introduction. When I was thinking about phenotyping and inflammatory in COPD, a few persons who came into mind, one of the top was Dr. Angira Das Gupta. I listened to Madam quite a lot of times in the conferences. He was the one who was pioneering in the simple methods of measuring airway inflammations, sputum eosinophilic measurement, and all the things. So, Madam is currently the additional Chief Health Director in the Medicine Department and in charge of the Department of Pulmonary Medicine at PR Singh Hospital and Center for Medical Education and Research, Eastern Railways in Kolkata. Madam has taken a big slot out of her precious time. Without wasting much of our time, we will request Madam to enlighten us about this topic. Over to
Thank you,
Madam.
Dr. Pallanivel, and for giving me this extra time. This is outside the time of your webinar. So it's a sort of in football, we have extra time. So this is an extra time for me. So I've been requested by Dr. Pallanivel to talk on clinical phenotypes of COPD. That's why, whom, and how. And I have decided to slides are not progressing. And I've decided to structure my talk today in talking about the diagnosis in very short, heterogeneity of COPD patients, the clinical phenotypes, the inflammatory phenotypes, and a multidimensional approach to phenotyping COPD. And I'll try and use clinical cases so that it's easier to put things into perspective. So at the outset, what is a phenotype and what is an endotype? So phenotype is something that we can see. It's an observable characteristic in an organism which arises from the interaction of genetic and environmental influences. So it's something that we can see with our eyes. But what is underneath that thing that we can see is the biological pathway. And this biological pathway is called an endotype. So for example, in a phenotype, we can see that we have late onset asthma. Whereas when we look at the endotype of that certain patient, it's a specific biological pathway, that is an IL-5 mediated pathway or an eosinophil mediated pathway. So that's an endotype, whereas the earlier one was a phenotype. But why do we need to bother so much about phenotypes? Is it that important? Guidelines somehow can get away by not doing a phenotyping, so why not we? The answer to this question is probably the fact that subset of airways do not respond to the usual guideline-based therapies, and this consists around 20% of the people with severe obstructive airway diseases. And for obvious reasons, it utilizes the maximum healthcare resource, and it also helps to understand the underlying mechanism and personalized treatment. So we'll be talking about the personalized treatment a little bit later in this presentation. So let's talk about this patient who is a 67-year-old male, smoker for 21 years with persistent breathlessness despite being on very high doses of combination inhalers. He is diabetic, has coronary artery disease, has benign prostatic hypertrophy. His exacerbation rate was pretty high, that is 3 in the past year, and the MMRC is a grade of dyspnea, which was 2. On doing a spirometry, yes, the patient did have a ratio which was less than 0.7, and hence 53%. The FEV1 was 61, whereas the FVC was reduced as well. Now, the chest X-ray revealed that there was hyperinflation, mild bronchiectasis, and the echo showed that the right ventricular systolic pressure was 35, which means moderately elevated. And he was on very high dose of the combination inhaler. So what do we offer him at this present moment? So I've marked in red quit smoking, and that should be the only, if this was another talk, I would have said that the first 3 things that the patient needed to do was to quit smoking, and quit smoking. But since this is a phenotype talk, I would say quit smoking as the first choice, and then all of these inhalers, all of these pharmacological agents have been used in these patients. And this is something very serious, where we have to understand what we are dealing with. We have to understand what the guidelines say and what the guidelines do not say. That's very important. So let's see if we can entangle and bring out things from the guidelines. So the first thing in such a patient, I would do a repeat spirometry, because sometimes we do not know what the spirometry has been done with, by which I mean the machine characteristics, what the patient has been on, what treatment the patient has been on. And if we do not take these things into account, sometimes the interpretation of the spirometry might become fallacious. So this patient has an FEV1 by FVC which was less than 0.7. Remember, the ratio was 0.53. And then we measured the post-bronchodilator FEV1 by FVC once more, just to check that the post-bronchodilator airways behaved like we thought it did. Here also, the FEV1 by FVC was less than 0.7. So this patient definitely had confirmed COPD. And now if we put this patient into the well-known grid that the GOLD has been able to come up with, it is simple to find out that the MMRC was 2, so it's not A, it's B or D. And the exacerbation rate was 3 exacerbations per year, so it's D, all right. Now, what has been suggested as a treatment for the section D? It's either a long-acting muscarinic agent, or a combination of a muscarinic and a beta-2 agonist, or a combination of a bronchodilator and an ICS, that's an inhaled corticosteroid. So now, does it seem to be very logical here? We do not know what we are treating. We are treating bronchial obstruction, all right. So we are giving them the bronchodilators. But what about the inhaled corticosteroid? We have not measured the inflammation at all. And without doing that, we are using inhaled corticosteroids in our patients. So Gold decided in 2025 that they are going to get rid of the C and D. So when they got rid of the C and D, what remained was the E. So this might look a bit weird when people do not know the history. But if you look at the exacerbation history and the functional grades and the spirometry, it's quite evident that the C and D has been replaced by E. And thus, our patient who has a MMRC grade 2, an exacerbation rate which is more than 3 per year, and a FEV1 which was 61%. And so our patient belongs to group E. Now let's see what we are supposed to do with this patient. The guidelines say that if the patient was belonging to the group E, then we could give a bronchodilator in the form of a beta-2 agonist or a muscarinic agent. And consider inhaled corticosteroid if the blood EOs are more than equal to 300. So now Gold has woken up. They think that we should give an ICS if the blood EOs are more than equal to 300. Now remember that our patient has an airway disease. So why on earth are we measuring blood EOs and not something in the airways? So we'll see what can be done a bit later on. And this is the follow-up of the patients. And we are supposed to target the predominant symptom that the patient suffers from. So if it's dyspnea, there is no need for giving ICS or an oral steroid. But if it's exacerbations, which are pretty frequent, we are supposed to give an inhaled corticosteroid or an oral medication. And if you look at the bottom 3 boxes, it says that roflumilast, which is an PGE4 antagonist, should be given if the FEV1 is less than 50% and the patient has chronic bronchitis, which means that the patient does not have overt airflow obstruction. And azithromycin if there were frequent exacerbations in the background of being a smoker. And what is dupilumab? It's an anti-IL-4. So this has found place in the COPD guidelines. It is quite clearly seen that if the patient has a blood use of more than equal to 300, after a course of LABA, LAMA, and ICS, then the patient should be given dp-linkmab. So it's there in the guidelines, all right, but it's not still completely clear to us what we are supposed to do with these patients who have proneness towards getting an exacerbation. So COPD is a heterogeneous disease. We all agree to that. And the heterogeneity spans over the etiology, the age, gender, and other things which we'll be discussing later on. See, the etiologies are varied in COPD. It starts off right from the early life when the genes are held responsible to be one of the mediators of COPD. There are exposures which are important, like cigarette, passive smoking, active smoking, biomass, occupational exposures, even those from, the mosquito coils and all the agarbatti that we use during pujas. They have all been in some form or the other held responsible for bronchial constriction in COPD. There have been different names that have been given by Gold. See, genetically determined COPD, so it's COPD-G. And what does it mean? It means an alpha-1 antitrypsin deficiency in a patient of COPD. So if you had an alpha-1 antitrypsin deficiency diagnosed, your name changes and becomes COPD-G. So I don't think our parents would ever change the names based on what we became, like Dr. Angira Das Gupta, so Angira D. But this is what we can see happening in Gold. If it was due to tuberculosis, infections, COPD-I, COPD-T, COPD and asthma overlap, COPD-A, COPD of unknown cause, COPD-U. So I find it a little bit humorous, but it's part of the guidelines anyway. So what is the effect of age on COPD? You see the age as the patient ages, this is the famous Fletcher curve, which has been modified a little bit. That as one ages, the FEV1 or the lung function gradually decreases. And there are certain conditions when the decline is increased. One such is if the child does not have a growth which is appropriate to his age, there is a growth failure, he could have a lower lung function. And sometimes if the patient catches up growth with the growth hormone in introduction via an injection, then the person could catch up on the lung function, increases with age. And very interesting, COPD in women has a higher prevalence. They are more susceptible to smoke, they have more severe symptoms, they have more COPD exacerbations, a greater decline in FEV1, biomass exposure effects are more. And the most important thing here is that the biomass COPD patients have small area affection. And we know that we have debates going on and on and on in all of the academic sessions where we criticize various forms of lung function tests as to which one measures the airway function the best. So we've not reached a consensus as yet in small airway function, excepting an impulse oscillometry. But still the cat is yet to be come out of the box. So there are more hospitalization rates in women. And lastly, there are more mortality in women. So women are on the wrong side of COPD. Now, like we said, that it's an heterogeneous disease. So the guidelines usually treat patients as if all COPD patients were the same. So that's traditional medicine. But now when we are talking about heterogeneity in the COPD patients, we are talking about stratification medicine. So how is the stratification done? Biological clusters in stable COPD has been identified, I think 5 to 6 years ago. And there were 3 clusters. One was an asthma-dominant eosinophilic disease. The second one was a COPD and asthma overlap with a neutrophilic inflammation. Cluster 3 was a COPD which has dominant mixed granulocytic. So eosinophils and neutrophils together. So, and this was done in the blood and not in the sputum. Clusters were also identified when COPD patients exacerbated: bacteria predominant, eosinophil predominant, viral predominant, quasi-granulocytic inflammatory. But what are the drawbacks of such? It looks very nice when we see the graphs. It looks, oh, everything is clustered in one area. It's pretty good. Then what are we worried about? A cluster analysis is usually a cross-sectional study, which is disadvantageous because we cannot follow up these patients, or we do not follow up these patients in a cross-sectional study. And when we do that, we can find that the patients can migrate across clusters. Meaning today a patient can be in a neutrophilic cluster, tomorrow might end up in an eosinophilic cluster. Hence, it may not respond to treatment according to the clusters. And there can be overlaps. See, if I go back to the previous slide here, you can see that there are overlapping areas, right? Unfortunately, in this figure, the overlaps do not have a patient that they had taken in account. Okay. See, successive exacerbations are different. The first one being neutrophilic, the second one can be an eosinophilic, and so on. So when that is the case, we cannot understand what a certain patient would be like because the patient is a part of a cluster. It doesn't guarantee a treatment similar, guarantee a phenotype of similar type in this patient. And this is where we break up further and we talk about personalized medicine. So each patient is different, each COPD is different, each person belongs to a different phenotype, and each person may respond to a different sort of a treatment. So this is very difficult, but we'll try and find out how to do it. By saying this, what do I mean? I mean that we have to tease out the clinically relevant phenotypes from all those jargons that we sometimes read in books. Because unless we can tease out the clinically important, that is the treatable traits in these patients, it's very difficult to treat them. Because clinics cannot look into the genes of a person. Now, if I were to say how many phenotypes are there in COPD, several, I would have gone on to read out all these numbers, all these phenotypes, but I will restrict myself because of time. But I will show you the last one, that's an exacerbation-prone phenotype, because this is the phenotype that to me is the most important one, because this is the one that can cause rapid decline in lung function, bad prognosis, and even death of the patient. So the trick is to identify the treatable traits and treat them. How do we do that? We just spoke about the etiology-related phenotyping, the gender-related phenotyping, but these are just demographic features which we cannot modify or treat when the patient of such a disease comes to us. But of importance is the radiology-related phenotyping, the pulmonary hypertension-related ones, and of course, the inflammation-related one. We've all seen these two people sitting in several pictures that we have seen since our childhood. Pink puffer and a blue bloater, a predominantly emphysematous patient compared to a chronic bronchitis patient. So quantitative CT scan is coming up in a very big way these days, where you can identify the small airway dysfunction in these patients. But again, the question arises that we can find out the patient has a small airway dysfunction, but then how do we treat it? No matter how much the inhalers, the manufacturer of the inhalers talk about the various particle sizes reaching various areas of the airways, it's yet to be understood completely well. Now, this is a very important X-ray, where on the left of my left-hand panel, you can see that there is a lot of air trapping in the upper airways compared to the lower, and the other one has air trapping in the lower zones compared to the middle and the upper. So why is this X-ray important? Because if you have an alpha-trypsin deficiency, then the COPD is usually, or rather the airway trapping usually occurs in the upper areas, the upper zones. So if you have a patient with COPD, X-ray looking like this, it's an alpha-1 antitrypsin, and we have to further progress to investigate. Now, this is something that makes very difficult for clinicians to treat such patients. You see, we had emphysema, we had chronic bronchitis, we had lung fibrosis, which was completely different and held a different sort of a spectrum of lung diseases. But look at here. We have pulmonary fibrosis, we have emphysema all clubbed together. So how is one supposed to treat these patients? It's very, very difficult to treat these patients, especially when we are in the era of so many inhalers, so many immune modifiers. It's really difficult to treat such patients, even though they might appear to have one of the treatable traits. When we have pulmonary hypertension and COPD, you can use the guidelines of 2022, the European Society of Cardiology guidelines. I wouldn't go into the details here, but I would point out this particular way of phenotyping COPD, which may be of help in our clinics where we see COPD patients. Emphysema, predominant frequent exacerbator. We know how emphysema is diagnosed. We know how a frequent exacerbator is diagnosed. Chronic bronchitis with a frequent exacerbator. We know how chronic bronchitis is diagnosed. We also know how exacerbators are diagnosed. Mucus hypersecretion, we know we have defined it in a certain way. And of course, a non-exacerbator phenotype. So now we can club radiology, lung function together. And these are some of the treatment modalities according to the phenotypes. Like the first one, long-acting bronchodilators would work across the spectrum. Inhaled corticosteroids, of course, not given in the non-exacerbator phenotype. Mucolytics, phosphodiesterase 4 inhibitors, and macrolides. Indeed, macrolides have been shown to be of help and keeping the patient free of exacerbations if given in the correct patient. Now, this is the most important part of today's presentation. At least I feel that this is the most important part. How do we do an inflammatory phenotyping? And believe me, this man has single-handedly produced such results in clinical research that Freddie Hargreave cannot be forgotten by all the stones, pillars in the walls of St. Joe's Hospital. And I was very lucky to have been there and worked for a fellowship there in clinical pulmonology. So this man defined obstructive airway diseases, or rather airway diseases, into three main components: airflow obstruction, airway hyperresponsiveness, and airway inflammation. And he has taught us how to measure each one of these components and tease out which one is the most important one amongst them and treat that particular component like it should be. Airflow obstruction diagnosed by spirometry, airway hyperresponsiveness by bronchoprovocation tests, and airway inflammation by this procedure, which is called a sputum quantitative assay. Very briefly, you take in the sputum in a petri dish, look into it through the inverted microscope, and take away the inflammatory portions, the portions of the sputum where the inflammatory cells are there. Add sputulysin filter through a nylon mesh and divide the filtrate into two parts. One part goes into the hemocytometer, which is mixed with a trypan, and we do a total cell count. And the second part goes into the cytosplin, where you can get a good slide and a differential count. So at the end of the sputum quantitative assay, what we really get is the total cell count and the differential cell counts patient, which guides us in treating such patients. This is one of the way the slides look like. So what are the types? Eosinophilic with a normal total cell count with more than 3% of eosinophils. Neutrophilic, more than 9.7 million cells per gram of sputum, more than 65% neutrophils combined, that is both eosinophilic and neutrophilic, and of course, polygranulocytic, which is a normal cell count. And how do we treat such patients? If a patient has just an eosinophilic bronchitis, we increase the inhaled corticosteroid dose. If it's neutrophilic bronchitis, we do not mess with the ICS, but we add antibiotics. And if the total count cell is high, we have to recheck after 2 to 3 weeks. Because sometimes the raised neutrophils and total cell count can mask a raised eosinophil level. If there is no inflammation, then you can give a bronchodilator to this patient. But do not mess with anything else. So if this was a 70-year-old male, wheezy since the past 5 years with an increase in the wheeziness recently, he was a non-atopic person, a smoker with more than 40 pack years, at least 25 emergency visits and specialist visits. FEV1 by FBC shows that both of them were reduced. Required prednisolone courses monthly. Symbicort is a combination inhaler, 10 puffs per day, that's humongous. Montelukast and theophylline to add to the music. Echo was okay, not that bad. But blood was a total cell count was normal with a 1% eosinophils. So the next test that was needed for this patient was the sputum quantitative assay, because this was a severe obstructive disease patients who required further phenotyping. Now, this is some of my data from my lab where it shows that if you did a eosinophil count by taking an absolute eosinophil count to be more than 300, 64% of the patients were eosinophilic and 36% were non-eosinophilic. This is the blood. But if you looked into the sputum, this is what came up. The eosinophil counts went down, whereas the neutrophil counts went up. And some of the mixed also reappeared. Now, why is this? Why do the eosinophil counts become low and the neutrophil counts become high? Our understanding is that we are over-treating our patients. If we give a lot of inhaled corticosteroids to a person who does not require that much, the neutrophil apoptosis is reduced. And so they add to the numbers of neutrophils, but actually they do not contribute to the disease. So this is something we need to keep in our mind when we are doing a sputum quantitative assay and inflammatory. So this patient had a total cell count which was 129, that's raised, neutrophil 97%, that's raised, eosinophil 0.3%, that's more or less normal. We treated the patient with antibiotic, and when we repeated the counts, lo and behold, they came up with 22% of eosinophils. So now the patient needs treatment with corticosteroids, done with the antibiotic part. And indeed, the sputum strategy has shown to be far better than the guideline-based strategy here. So if we sum up the heterogeneity of COPD according to the inflammatory or inflammation that the patient has, the patient could have an airway neutrophilia, eosinophilia, systemic, or no inflammation at all. So this is a non-proportional Venn diagram. So you read the numbers, but do not go by the volumes. But like all investigations, sputum assay also has disadvantages. It needs a wet lab, a trained personnel, has to be processed within 2 hours of collection. Sometimes there is no sputum. So what do we do then? We do some fluid phase measurements, like Dr. Raghavendra must have spoken earlier about, and we see the proteins. And these are just preliminary results. You can see the inflammatory proteins are not all of them, but the signatures are different in some of the neutrophilic proteins. Oxidative stress-related proteins are again different in exacerbators and non-exacerbators, whereas mucin-related proteins are again different in exacerbators versus non-exacerbators. So if we combined everything and did an approach to a patient or to phenotyping COPD, we could well say that the eosinophilic airway inflammation best diagnosed by a sputum quantitative assay would be treated by a corticosteroids, either an oral one or an inhaled one, but no antibiotics there. So no drug, no organisms which become resistant. Neutrophilic airway inflammation diagnosed by a sputum neutrophil count of more than 60%. We can give azithromycin 200 milligrams daily for 3 months to reduce the degree of inflammation or the exacerbation proneness. Postgranulocytic, just bronchodilators like we were treating our patients. Mucus hypersecretion is coming up in a very big way in asthma in the future. We can use non-pharmacological methods of treatment, mucus hypersecretion. And if there's a systemic inflammation, some people have suggested using a simvastatin, but that's not usually followed in clinical practice. So in summary, COPD patients need phenotyping, especially when guideline-based management fails. Cluster analysis has its own disadvantages. Phenotyping based on the type of airway inflammation seems to be the best so far. Blood eosinophilia in India does not mean that they are activated and contributing to asthma or other inflammatory diseases. There may be blood eosinophilia and no airway eosinophilia, and vice versa. And a multidimensional approach is in the need of the hour. Thank you very much. And I will be happy to answer if there are any questions.
Thank you so much, madam. That was so enlightening and interesting. It was very crisp, and I think the postgraduates would have definitely benefited by your lecture. If any PGs have any questions or any faculty, the forum is open.
And Dr. Pajniwal, I've just put it in the chat box.
Yeah, Dr. Anupama, madam. Yes. Madam has asked, why sputum cytology not done in many centers? Why not in guidelines as
Only in
precision medicine?
guidelines.
Yes.
Yeah.
So I would be a little bit harsh in answering this question because if you don't do a certain procedure which is helpful and easy to do and trainable, I think I would need to ask myself and my heart and what they say. It is indeed very discouraging because in one of the conferences, I had done a pre-test and a post-test evaluation. And in fact, that was part of my societal project of my PhD thesis. And I was very disappointed. In both the cases, the doctors seemed to know everything about inflammatory. There was not a single wrong question when questions were asked about inflammatory. And the last question that I had is that, are you willing to start your own sputum lab? And the answer universally was no. So I think we need some introspection there.
That's true. That's true. I think
would anyone here now really think that you would like to do a sputum lab or start a sputum lab?
we all of us will definitely want to have a sputum lab. In fact, we made attempts to that, but unfortunately, the quality of the technician, what we get, it was we need to think twice in continuing that process.
So next time you have thought twice, you think thrice, and you can contact me at any point of time, and I'll be happy to help you with it.
Definitely, ma'am. And now we got the path ahead. So we'll definitely take your support in establishing a sputum lab. I think the only thing we need to have a separate location in the sputum lab, or we do in our own department. What is your experience, ma'am?
So I have a different room where I do this because the other rooms are used for molecular diagnosis of infections. So I separated and it's and I take a pride in saying that I am not part of the pathology department. I'm an independent entity who's doing this test.
Madam, this is in our medical college. It's done by the pathology department, and they don't encourage much. They said it's very cumbersome. We don't have technician. They are not adequately trained.
So this is again like Indians are always very interested in picking up flowers from a garden which has already been set. So you need to take your own plant, own fertilizer. You need to sow the seeds, and then the rose is going to be really good and big.
That's true. Definitely, I think we'll get back to you, ma'am, on the guidelines of a starting of a sputum lab. I think it's a doable. Most of our wards have a small side lab. So we
It's
can.
very simple, and the only expensive machinery that you will require is a cytospin and an inverted microscope. That's it. All the remaining are just 20,000, 10,000 and all that.
So how does it go, ma'am? Like every COPD patient you see in your clinic gets the sputum done, or
No, 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 no.
ah,
So if the symptoms are not being controlled by the standard guidelines, that is the gold guidelines,
okay,
that is when we do. Because most of the time we want to apply the biologics. So if we do not do the sputum, I wouldn't feel comfortable. Just by seeing a blood eosinophil of more than 300 counts, I am not going to take it that the sputum eosinophils are also raised. It might be that it's just a parasitic infection that's going on in the patient, which we have not entertained.
Madam, when biologicals had come up for asthma management,
Mhm.
then in those cases they had stressed it regarding phenotypes for asthma based on the
Yeah.
sputum eosinophilic count, pheno, and other values.
Mhm.
So I think even that could have been given a more insight to have sputum assays done in most of the colleges or the hospitals because it
Definitely,
came in the guidelines. Yeah.
definitely. When you should necessarily do it. It should be made mandatory to do it. So that's what I feel.
it's-
Thank you. Thank you.
that-
Because if you give a biologic to a wrong person, a wrong
Yeah.
patient, then it's a disaster.
True.
True.
So I think the basic purpose of why I invited madam is this point. Madam will say that yes, without sputum, you cannot do treatment of COPD effectively. This is
So
like
sputum is such a thing that in Calcutta we have this Howrah Bridge. You must be knowing about the Howrah Bridge.
yes.
So at one side of the Howrah Bridge, it's written, "Please do not spit." And so Indians are good spitters sometimes.
Right. Right. So the other interesting part I wanted was that statins in COPD. That was one slide which was very interesting. Systemic inflammation, go for statins. And you also said that we don't follow it clinically.
Yeah, so I don't think anybody follows it.
Yes.
So if you have systemic inflammation, we would give an oral corticosteroid. We would not give simvastatin.
What is your take on that, ma'am? Should we follow that as well? Like, I think
No, no, no. I'm completely not in that game.
okay.
No, because we are giving inhaled corticosteroids, we are giving oral corticosteroids. So simvastatin is something which, if given, causes a liver dysfunction. So why should we do that?
Fine.
So the standard method of treatment, stepwise in asthma, would probably be to find the diagnosis of asthma, to do a correct phenotyping by doing sputum assay as well as the other assays, and then prescribe your medicine in the form of oral corticosteroids or inhaled corticosteroids. If the patient requires such a dose of a corticosteroid which causes symptoms and side effects, then we should do a biological therapy. So
Any other
that
questions?
sounds logical.
Yes. Yes. Any other questions?
Yes,
Vimal?
sir. On general take on how realistic are we, or how fast are we in early diagnosing COPD patients? That is, patients with risk factors. Is it possible to diagnose them before 40 years? Smoking clusters or
See,
people with
my answer to your question would be that why don't you do it in your own clinical practice? If you do that, then you would realize the number of patients we are missing or the number of patients we are overdiagnosing. So only when we do it hands-on in our own clinic, I would not be happy about reading the gold guidelines.
Madam,
It's
how
very simple.
frequent? Yeah.
No, Plam, please go on.
Ma'am, how frequently you're doing CT in your COPD patients? Particular indications as per the guidelines only, like for pre-COPD, lung CS screening, or any other specific indication?
Okay, so to be very truthful, by the time I see the patient, the CT scan has already been done. So
True.
all the residents, they are very eager in getting a CT scan done, even if they can diagnose the patient of having a right upper lobe pneumonia. they would still say, ma'am, we might be missing a lymph node somewhere. So God knows what the lymph node is going to provide, an extra disease or a different interpretation or a different treatment. So having said that, if I were given the first on call of that patient, I would probably reserve doing a CT scan only when the chest X-ray appears to be a non-interpretable one. So,
Yeah.
and the small airway dysfunction can be diagnosed from the expiratory as well as the inspiratory films. So that is one place where I usually do a inspiratory and an expiratory CT. Yes, that's it. So do you follow the same thing or something different?
Yeah, mostly like same. But the specific prototype of that quantitative CT,
Yeah,
that's not freely available.
no. So it has to be an objective assessment for us, unless we get more of the quantitative CT algorithms uploaded.
Ma'am, what is your take on this high outdoor temperature and low outdoor temperature in 2025 guidelines, which increases risk of hospitalization and increase risk of exacerbation?
So in the thing that I understand after reading that is that the humidity should be a more important factor than the dry hot air. So because that's when the infections tend to come into the system and cause all sorts of diseases.
Okay, basically the humidity part.
That's what I think. I may be wrong, but that's what my brain tells me.
Ma'am, you are having so many innovative ideas and innovative methods. So why not we use some environmental sensors to detect some sensors for environmental and outdoor pollution?
So I'm not a pollution person, although I'm sitting in
Maybe.
the middle of polluted Calcutta.
Dr. Anupam, madam, what exactly that? The environmental sensors for what?
No, no.
Measuring pollution
What I
or
was saying
monitoring?
is, you know what? Whenever the exacerbations are increasing,
Okay.
there is some digital health technologies which have come up wherein actually they have shown the increase in the use of rescue inhalers in
True.
asthma exacerbations.
True.
So, they have identified that yes, during those are the days when the environmental pollution was at the highest.
Absolutely. The trend in the
That's the trend,
particulate
I would
matters
say.
in the
Yeah,
correlates with the exacerbation frequency.
correct.
So
Yes,
there
that's
was one lady.
that's
So we had one faculty. Remember, you must be knowing about the MECOR program that
yeah.
the
Yeah.
ATS people come to India and do. So
Yes.
in that program, there was one girl who was, I think, of Chinese descent. So she was very friendly to all of us. So in the evening when we used to go outside, they said, "Do you want to go for a walk?" I said, "Okay, fine, we'll all go for a walk." You know what her intention for going for a walk was for? She used to carry a small instrument, something in her hand, and we are walking and she's measuring air
Oh my.
pollution.
Okay.
Interesting. Right. Any other questions?
No,
Postgraduates?
please. No more.
Ma'am, I think definitely the thrust now will be like I think whoever is part of this audience, they will definitely take sputum testing as part of their workup in COPD with your guidelines and expertise.
So one last anecdote I'll tell you
Yes.
is that when I went for getting the American visa from Canada, so my mentor, Dr. Nair, told me, Angira, make it a point to tell your interviewing person that you were doing a project on sputum and he would let you go. So be careful when you say you're doing a sputum study.
Yes. Yeah. Great. So, how long were you associated with Dr. Nair, ma'am?
It's more, even now.
Okay, I know. No, I mean that's it. Like I mean that academic.
I did a lot of work with him in 1 year.
Okay, that's so nice of it. That.
So do you know him by any
Yeah,
chance?
I've met him in conference. Even last 10 days before, he was there for an ERS thing
Yeah, one
online.
of the mucus
Yes,
secretions
yes,
program.
mucus in bronchiectasis. That is the thing. That was
Yeah.
very interesting to listen to him. Right.
But again, what I felt about that program was the clinical application was not that good as of now. So more work needs to be done.
Yeah, absolutely. It's all more of research oriented and this thing. But at least we had insights what's going on in this thing.
But even in bronchiectasis, they are typing based on the inflammatory markers like neutrophilic, eosinophilic, and macrophage. No, endophenotyping is occurring for bronchiectasis.
No, it's the Venn diagram that I showed you, the 3 component of the airway
Yes,
disease
yes, ma'am.
section.
Yeah.
I think all airway diseases fit into those 3
Fitting.
components.
Yes.
Yeah, so I'm not sure if the students are memorizing this because that's not there in any of the guidelines, and they might get punished if they talk about all these things.
No, but that's the fundamental concept they should understand. Any inflammatory
Yeah.
disease has to be having this. So maybe the last request I can make you, ma'am, if you have some guidelines or the SOPs how to set up a sputum lab in the Indian setting, I think
Sure,
the
I'll be happy to
local
share it.
resources we can start it availability.
Yeah, sure. Please do share, ma'am.
I think a request to Angira madam to please
Definitely, I will be more
forward
than
these
happy to.
guidelines. We will. And maybe inauguration, we can invite you in person so that we can meet one more wonderful talk. Yes.
Thank you for
So
saying
thank
that.
you. So any other comments, madam? Dr. Anupama, it was nice to see you online
I
again
know.
from
Thank you.
Coimbatore and
Yeah.
after NAPCON. Very there for NAPCON, ma'am, Dr. Angira?
Yeah, I was there in the NAPCON, yeah.
Oh, we missed you. Everything.
Last day,
Oh,
and then my flight, I had to catch my flight, so I was very naughty, and I went up to
okay.
the chairperson and said, see, I'm going in first. You cannot have me on the 3rd slot.
Oh, great. Okay. Right. Thank you so much. And we'll close this session because we are already ahead of our
And I'm
schedule.
very thankful
Thank
to
you.
you for allowing me to come
No,
so
ma'am. I
late
think
to the
knowledge
session.
needs to be shared at whatever cost. Right. There's
Thank you.
nothing like
Yeah.
we will take. And thanks to the ECHO team for accepting our request to postpone this session and make this an event session if possible. We will continue with this resonance every quarter, ma'am. Maybe next quarter being the March, we'll something on tuberculosis. I'll share the invitation to all the existing audience also. So